For those of you who don't already know me, I'm Dr. Lonnie Zeltzer, and I started CHIP after 30 years as head of pediatric pain and palliative care at UCLA. CHIP it's all online, it's a nonprofit. We don't do treatment, but we empower youth living with chronic pain on how to alter their brain circuit through healing experiences, education, knowledge is power, and peer support. Same for parents. Um, and I'm really excited today. We have two experts. First, we have, before I do that, let me tell you the title today is Creative Healing for Youth in Pain, and our webinar is Functional Neurologic Disorders, Pieces of the Pie. And for any of you who have seen kids or young adults with FNDs, they may have seizures, they may be blind, they have all kinds of neurologic disorders, but they often have a lot of baggage like POTS and Ehlers-Danlos, hypermobility. They may have pain in other parts of their body, migraines. It's pain usually travels with company. And we have really two experts, people that I truly admire. Michael Chung, you can wave, is a doctor of physical therapy, and his training is in neurologic PT. He's at Reactive PT and Wellness in LA, and he's their CRPS, Complex Regional Pain Syndrome Program Director, and his expertise is beyond question. He knows more about functional neurologic disorders. Among all the PTs I know, he's fabulous, and he continues to take courses and be sent to learn. He did research in neuroplasticity. Anyway, he's brilliant. And then the other brilliant person we have is Malia Sako, who has a doctorate in occupational therapy. She's also a yoga instructor. And again, she works together with Michael and the most complex of complex kids and adults, because the most complex are whom I sent to reactive PT and who goes there. And we'll talk about, her approach, which is very unique and different from just going to an OT. She has much more of a lifestyle redesign approach to OT, and we'll talk about that. And the two of them are just phenomenal duo. Maybe start with, for those who don't know, what is a functional neurologic disorder? It has so many names depending upon what part of the body or parts are involved. Could either or both of you talk about that?
Yeah, I feel like this question alone could probably be an hour-long webinar or more, but I'll give a succinct, not comprehensive take on it. But FND is a neurological condition that impacts the functioning of the nervous system. So primarily the signaling that goes to and from the brain. And it can present as a lot of things, as Mom mentioned, motor symptoms, cognitive changes, sensory changes, dysfunction of the autonomic nervous system, and changes to mood and stress response as well. And while there are exceptions to this analogy, and I think this definition has been changing, but there's often a software and hardware analogy. So the hardware is a change to the structure of the brain. So for example, a traumatic brain injury, where scans can be done and there's a physical image that shows that damage has been done to the structure. But for FND, while that can happen and be a comorbidity, it is more of a software issue. So it is the signaling, the communication within the nerves of the nervous system, and it's not picked up on imaging, which can be a very frustrating diagnostic journey because there can be many labs and imaging that's done, and it shows that everything is normal, even though kiddos and families know that things are definitely not normal.
Yeah, and I would just add that FND is not a new diagnosis. Maybe the diagnosis has been rebranded a few times. I mean, there's this long history going back from ancient Greece, how they thought something about the uterus and the womb was moving around, that turned into hysteria and conversion and somatoform disorder. But now we have functional neurological disorder, which is a lot more comprehensive. It takes out the stigma of just psychology, and it really accentuates that this is a multifactorial disorder.
In very pictorial terms, I see it as accumulated stressors internally, externally, whatever in vulnerable people, maybe by past history of trauma or who, accumulated, but the system can't hold itself together anymore. And I want to say it explodes like a volcano. It has to let off steam, and the goal of treatment is re-regulating a system that's gotten just so out of balance that all of these neurologic symptoms, or the signaling system, is kaput. There are a lot of, like UCLA and their neurology, the idea of functional, what is it called, non-epileptic seizures, where people have seizures and their electroencephalogram is normal, but they look like they're having grand mal seizures. And it used to be more in psychoanalytic terms, they used to call it, psychiatric.
Conversion.
What?
Conversion.
Conversion. Thank you. I couldn't think of the word. Conversion reaction, and maybe the form it takes may have some unconscious contributor, but that's not all. And conversion makes it sound like it's all psychiatric and you just need a psychiatrist to fix it. And psychogenic, non-epileptic seizures. But it comes in all forms, in blindness, deafness, can't walk. I mean, it's all functional neurologic disorder. So somebody is asking, I'm curious if you have ever seen DID as a symptom of FND, or if that would be a comorbidity. And you have to explain to me what DID is, if you know, Michael and Malia.
Hey, DID, dissociative identity disorder.
Thank you.
We've seen both, where some folks will kind of dissociate and maybe, have some sort of different presentation. I think most commonly, the ones that are like, most common presentations are like turning into a child. I've also seen someone turn into a cat, but a lot of times it's not, there could be this like functional seizure aspect to it that relays this different personality and different identity. But we're gonna talk a little bit about this more in the webinar. There definitely be a lot of overlap with different.
If we think about the multifactorial component, usually it's not just this neurologic change, but there are a lot of other things. Can you talk about some of the other pieces of the pie that sort of play into this that you see?
So the different pieces of the pie, we'll kind of break it down into two different ways. So I'll kind of take what I primarily do in physical therapy, and then Malia will share what she does in occupational therapy. But the different pieces of the pie are motor control. That's not, like how strong you are, but it's like how connected you are to your whole body. Physical limitations, that's what everybody knows PTs as like strength, flexibility. And then there's the sensory system, which is more than just the somatosensory system, not just your touch, but also your vision, your vestibular system, your hearing.
Some other pieces of the pie too, psychosocial slice of pie is important. somebody's psychological history and their social supports are incredibly important to their FND, how it presents, and also their recovery. Lifestyle factors is another big slice of the pie that OT is usually the hub of on our team. So things like how sleep, eating routines, pacing and energy management, stress management, how they're able to engage in school. There's kind of this bi-directional relationship to FND where FND can get in the way of a kiddo's lifestyle and lifestyle can help or hinder. So that's a big slice, and also autonomic changes. So I think I might go as far as to say 100% of the time are working on that slice of the pie and how the autonomic nervous system is affected by FND, but how it can be a part of the treatment.
Can you clarify if FND applies to all the kids in the CHIP program? And I can answer that. Of course not. There are kids with FND and kids without. Not all kids with POTS or EDS have FND. Not all kids with FND have POTS or EDS. So it's a matter of looking at what parts of the system are not working well and what is that getting in the way of? And how do you evaluate that? And how do you begin to develop a treatment plan?
So I guess evaluating it, we always start with hearing the person's story, because a lot of times it wasn't this one event that caused the whole functional cascade, but a perfect storm of events that might have happened. For example, a breakup or having COVID, and at the same time, parents are getting divorced, and all of this sort of happens all at one time. So we'll evaluate them just based off their subjective first and build out, well, what pieces of the pie are the largest pieces of the pie? That way we can almost eat up that piece of the pie first, and their FND can, or their symptoms can also decrease. With the motor control piece, I'm really looking at if their attention changes their symptoms, if the change of environment changes their symptoms, if it changes with doing two things at one time. With some of the sensory things, I'll almost like write out every system, and we'll go through what works and what doesn't work. A lot of that is subjective, but they'll do some sensory testing with Malia as well. And with the physical limitations, a lot of that could be, addressing the stiffness. I think some examples, well, they're not done as standalone in each piece of the pie, but some examples that we'll do to create automaticity of movement and fun is dodgeball. We'll do painting, we'll dance. So it's not, the physical therapy side of things is not your typical physical therapy, but trying to make things a lot more automatic and reconnected with the whole body.
So our psychologists are, of course, our main hub for the psychosocial slice of the pie. But I would say all of our team members with all disciplines are psychologically informed, trauma informed. But the psychologists are usually there to do the main assessment, taking a look at trauma history. It may be present, it may not be present. Looking at belief systems and how we can rely on strengths for the kiddo, but also maybe if there's thought patterns and narratives that we can challenge to help them along the way to recovery. I feel like ones that come up oftentimes are like perfectionism, the need to like push through. So those are some belief systems that throughout all the disciplines, but definitely psychology, we're really kind of taking part. I feel like there's a lot more to say about the psychosocial, but for lifestyle, as I mentioned, that bi-directional approach. So sometimes folks have never had sleep issues until FND started. So FND really caused and set off sleep issues. For other kiddos, there's been sleep challenges for a very long time, and it's now exacerbated by FND and making it harder to recover from FND. Their nervous system is dysregulated. So we're looking at all those different factors of lifestyle and seeing what has changed recently since onset of symptoms, but also what was the existing lifestyle factors before. And for the autonomic nervous system, we like to use HRV monitors to just take a look at kiddos like baseline heart rate variability.
Could you explain what that is, what heart rate variability is different from heart rate?
Yeah, so heart rate variability, we kind of use that as a proxy for how the autonomic nervous system is doing. And there's, I feel like, a lot of different ways to describe it, but it can be the variability between the heartbeats, so the length of time between heartbeats. Sometimes it's described also as the ease of the nervous system to switch between sympathetic and parasympathetic, which we need to be regulated. So we have a little device that allows us to get their baseline, but also it's pretty cool to track live time as we try out different autonomic regulation techniques. And I should say a higher HRV means that we're more regulated, and a lower HRV means we're less regulated. So we get to see how the HRV changes, or if it doesn't change at all, as we try different techniques. And of course, the kid's subjective take on the strategy is always number one, but it's nice to have that number. And I think that resonates with some kids.
Is it helpful to track the symptoms or see if there are certain things internally or externally that might bring on a symptom, an FND episode?
Yeah, my answer is kind of a non-answer. I would say yes and no. It's kind of about finding a balance, right? So we know that too much internal focus, so too much focus on internal sensations and symptoms is not so helpful and can exacerbate symptoms. We also know that not being in touch with the body at all, having very low interoception, is also not helpful for recovery. So it's really important for us to meet the kid, find out kind of where they are along that spectrum, and decide, do we need a little bit more exploration of internal sensation, gaining insight about what's going on in your body, or do we need to take it the other direction? Like, let's not track anything and let's just bring our attention externally to things that are fun or, happily distracting.
Yeah, and we'll know that right away. Like the kids or the person in front of us will either have a journal with everything that caused all our symptoms, or they'll say, I have no clue what the pattern is, and that helps us guide which direction we're going.
When you're working with kids, and I say that sometimes up until their mid-20s, if they're living at home, you also have parents, family members involved. How do you educate the parents so they're not aggravating, or what do they do during an FND episode? How do you help the other family members facilitate what your goals are?
A big part of FND recovery is autonomy and agency. So I do always like to check in with the kid of, do you want your parent or family member here for all of the session, just for the first 15 minutes, last 15 minutes? Because I do find it important to integrate family for carryover and for understanding. But as far as what to do during an episode, that's definitely a whole family treatment session. And I find that it's helpful to come up with an episode management plan. Sometimes families already have that, the do's and don'ts of what to do when a kid's in an episode. But oftentimes we come up with it with the child leading that conversation. Oftentimes in an episode, as I'm sure many of you know, it's hard to communicate. It's either hard to speak or hard to gesture. And so it can be a form of autonomy and agency if we come up with a plan when a kid is hearing coherent and okay. So they know that when they're having an episode, folks are treating them and reacting in the way that they chose.
We'll do our best to create family meetings as well. So they'll meet with either one person on our team or the whole team to figure out what's working well, how can they support their kid at home, what are the do's and not to do's.
One of the psychologists is in the chat box. She's saying it's important to look at what emotionally is also related Sometimes it is literally directly causal, such as going into seizure to shut down or kicking a leg when mad at someone. Can you address that, sort of the relationship between the emotion and the FND, whatever that is that the body is doing?
Yeah, absolutely. Like we mentioned, that there's this psychosocial and emotional piece that could be related to FND, not in everybody, of course, but in some people. And a lot of times, too, what we might end up doing there is supporting the child's nervous system and emotional recognition in comparison and along with their interoception. So, for example, one client that we have, she gets she gets a lot of pain, and when she is in a lot of pain, she might get a little bit violent. So we've done work on, well, what are you feeling when you are in pain? Well, my leg is hot. When I'm feeling hot, I feel angry, and almost linking up those emotional pieces with the sensory pieces to the physical pieces.
Mhm. How do you help the parents not inadvertently feed into it? For example, I had a patient, not doing this anymore, but who would just have these drop episodes where she'd fall and and this was long after a concussion, and her parents would feel like she's hitting her head, she's having another concussion. How do we stop that? How do we protect her?
Sometimes, not always, there are episodes in the clinic. So while it's never fun to have an episode, it is a moment for all of us to kind of explore and try out new ways to manage an episode. And fortunately, unfortunately, we work with kids and adults who have episodes all the time. And so while it is scary, I think we're able to keep a calm, soft voice and demeanor, grab the tools and strategies that's needed. The whole clinic is informed with this. So sometimes, I know Michael has once ran to go grab some sensory tools while I stayed with the kiddo and protected their head, right? So I think modeling, like role modeling, new and different ways to act and behave during an episode can be helpful. There's something else I wanted to talk about.
We try to set up the scene as great as possible. So we almost set the scene that FND flare-ups are definitely going to happen, right? So these flare-ups can happen, these episodes do happen, but we have to find a way to either prevent it from happening or find tools that can regulate our nervous system. The way I kind of describe it is it's almost like driving up to the mountains, right? Sometimes you're always going upwards, but sometimes there are dips in the road where you're wondering, am I going down or am I going upwards? But towards the end, everybody does tend to get better, and you can expect full recovery.
Can you give examples of sensory overload episodes?
It depends on the kid, but oftentimes sensory input can be a trigger. Sometimes it is like it's based to one sensory system, but oftentimes it's the overload of visual, auditory, smell, also just the newness. I need to actually track data on this to back it up, but I do feel like week one of programs and like first day can be an episode heavy day because it's a bunch of new people. There's a lot of attention and focus. There's lights and movement in the clinic and sounds. And so that kind of cacophony of everything coming together can trigger a sensory overload episode. And that might look like dissociative. It might look like a seizure. It could be paralysis. It can show up however their symptoms.
A comment in the chat box from a mother says, my daughter was diagnosed with CRPS. Michael, you're the CRPS expert. Last May, left leg only, she can't walk. Pain was terrible. They went to Kansas to Mercy Children's Hospital for their RAPS program. I'm guessing that's pain rehab, trying to get rid of the pain. But during the first week, she was pushed in terms of pain so hard, she started having seizures. What should we do? So obviously you can't say what that particular family, but maybe explain what happens when kids may be pushed beyond what they can do, starting with one problem and then having it be a systems problem.
Yeah, absolutely. First thing I like to identify is, well, what are the triggers and what is soothing for the nervous system? So for functional neurological disorder, I mean, neurological is in the name of the diagnosis. I am looking for things that are going to regulate their nervous system right away. That can look like what I have here. I've got fidgets for myself and a weighted blanket. We've all got fidgets here. They're everywhere. It could look like that. Some people don't really resonate with that. We try to create a very personalized picture of what that would look like for the person. Some people really like rocking or bouncing, and some people it's the complete opposite. I don't want to do anything relaxing. What relaxes me is doing something active. And yeah, there's definitely no one size fits all in this whole situation.
One of the parents comments in the chat box, and I hear this a lot, parents of kids with FND appreciate the parent education that comes also with empathy for the parents, because they're already blaming themselves and they have so much guilt. And that sometimes, and I'm adding to what was said based on other parents I've heard, they end up feeling so guilty or so bad that they do things that maybe intellectually they know isn't helpful to their child, but they're feeling so guilty seeing their child suffering. That how do you help the parent really absolve the guilt and really do what's most helpful for their kid and take care of themselves?
We definitely include family as part of the treatment team. That's like they are a huge part of the treatment team and are struggling as well. And we definitely recognize that. And I think taking a collaborative problem solving approach is always kind of our MO, right? It's not a, you should do this, you shouldn't do that, why did you do that? That's definitely never the flavor. It's like, hey, like, what have you tried? What's working? What didn't work? Right? Okay, here's some thoughts. One family we know tried this. Like, does that sound like something that could be helpful for you? Right? It's a very like team-based approach because we also don't know what is perfectly going to work. So we're not here to tell people what they did was wrong or they should do this instead. So I always hope that that kind of team-based approach helps parents learn in a way that isn't self-blaming. We also recognize too, sometimes parents will want referrals for their own therapy. We also have a parent support group as well as part of one of our FND membership. So we definitely want to support the family as well.
And hopefully to absolve any feelings of guilt for parents, is that it's not your fault, it's not the kid's fault either. A lot of times with FND, like you mentioned, it's a perfect storm of events that have happened. And I mean, like one of the pieces of the storm could be, you know, maybe the child has Ehlers-Danlos syndrome or postural orthostatic tachycardic syndrome, EDS and POTS, right? So this is no one's fault, right? But they all can contribute to someone developing FND.
There's a question that I think is a good one because I get asked a lot by parents. Can you give some examples of the do's and don'ts that you're referencing, especially when their child is having during a non-epileptic seizure?
Yeah, I think it's easiest to start with the don'ts, right? And these are, of course, very general answers here, but I think the biggest don't is once you've identified that this is a functional seizure, I don't know if we're still using this in the chat, non-epileptic seizure. Just as an aside, I think we're moving away from that term because it's telling you what it isn't, where functional seizures tells you what it is. But that's an aside. As a general, once you've identified that it's a functional seizure, you definitely don't call 911. And then I would do a like what is going to help you before the seizure, right? So having that conversation with your kid. If your kid doesn't have that insight, either working with the therapist or you probably as a parent have that insight of, oh, I've noticed that when you do X, Y happens. So what can we do to change X a little bit so that your nervous system can feel a little bit better?
It really depends on the kid and their nervous system. We find sometimes kids really want calming, soothing, grounding input. Some kids we find actually have been doing that and it's not working, and they actually need things that are quite stimulating. So an ice roller along the face. If they're able to, safely suck on a sour candy, something like that. One of our kids really responded really well to country music, turned up pretty loud and some tapping along on her leg. So that's a great example of like how individualized it is, and it takes a lot of exploring for what goes into the do's and don'ts.
Who should be on a team? So you have the parent has a kid with functional neurologic disorders, and they're looking for help. And, I know my own bias is if they're driving all over the place to find an OT and find a psychologist and find a PT and acupuncture and while all of these things, yoga teacher can be very helpful, what constitutes, at your place, what constitutes a team, and how do you evaluate who should be on the team and how you develop a plan, a program?
Yeah, the non-negotiables I would say is that first you have to identify your team captain, and everyone that answer is easy. The team captain is the kid, is the person in front of you. You might be, as a parent, their crewmate, and the other non-negotiables I would say who are on the team typically are physical therapists, occupational therapists, and psychologists. I will say that every of these like healthcare disciplines, just like doctors are, right? You wouldn't go to see your dermatologist for an emergency room visit, right? So you have to find the therapist who is knowledgeable in functional neurological disorder. But yeah, this team also doesn't work if it doesn't function as a team. So having everyone communicate with each other is really important, which is why we have our model where everyone stays under the same roof. That way, you see me first, and then you go next door to see Malia, or Malia will just join in our session too.
We take a transdisciplinary model, so we're trying to get used to using that language because it really reflects what we do. And I found a great image. I wish I could give credit where it's due, but describes the difference between multidisciplinary, interdisciplinary, and transdisciplinary. So a multidisciplinary team, you can picture individual circles of like PTs, OTs, yoga therapists, psychologists, dietitians, and a interdisciplinary team. Those circles are all overlapping a little bit more, right? So that like communication is happening. They're talking, working together. The transdisciplinary model, I describe it to folks as like reactives model is like a Venn diagram that's basically a circle. So we're all taking into account everybody's approaches. In our programs, we have team meetings, so we get a half hour carved out each week to talk about the kiddo and what's going on, what's going well, themes that are arising. And so I think the team members are important, but the model and dynamic that which they're working through is also great.
Right. No, I totally agree with you. Have you seen the FND rise after environmental exposures to mold, chemicals, food additives, etc.? And I'll add to that, after COVID?
Yeah, absolutely. I think I guess the most common causes of FND that I've seen so far, just most recently, number one would be COVID. Another one would be like black mold exposure. Sometimes even like trauma, whether that's physical or emotional. Yeah, or surgical, right? Surgical or anesthetic.
If a nervous system is out of balance, is upregulated, are there ways at home of downregulating the system?
Yeah, for every kiddo, again, everything is different. So I think like at its fundamental level, identifying if your kid is maybe hyposensitive or hypersensitive, and then building a plan from there. But the most common strategies that we see are using a weighted blanket, rocking chair, sometimes abdominal binder, especially with like kids with POTS. Bubbles end up being a big hit here. Almost facilitating that breathing, but taking it outside of the body. A lot of play ends up being the most regulating for kids and adults.
What about genetic disorder profile? So, and I think about some kids, and whether it shows up in genetics or not, who are neurodiverse. They may have ADHD, they may have learning disabilities, they may be neurodiverse in terms of autism spectrum, having nothing to do with brilliance. They may have EDS, the kind that doesn't have a genetic marker, but we know is EDS. Do you assess these or have them assess them? Does that play a role? How do you evaluate that? What are all the pieces of the pie that you try to address in the rehab model?
Oh, yeah. So I guess that's a great question. I love this question because this is a new and trending area of research and things that we are seeing in the clinic. So yes, EDS is a common, I guess, comorbidity. I think why we see FND and EDS kind of overlap is that a lot of the pieces of the pie do end up overlapping. EDS, you have these hypermobile joints. This hypermobility changes into proprioception and sensory pieces of your body, and that changes your interoception. These are all things that we've already discussed for FND and have a lot of overlap. That with postural orthostatic tachycardic syndrome, POTS, has that dysautonomia piece into it. We'll see autistic spectrum disorder in the most recent Italy conference. A doctor there had shared that 15 to 20% of our kids who come in with functional seizures also have epileptic ones. And that's 15 to 20%, where the general population has 3%. And you also see this in adults. 70% of people with Parkinson's also have some sort of functional symptom along with their Parkinson's. So there's definitely a lot of overlap with genetic, non-genetic, and other comorbidities with FND.
Somebody in the chat box, and I'll comment on this, said by COVID, do you mean the disease or the pandemic culture? So the idea that families of a kid who's had COVID and then sort of decompensates long after COVID should be over, so they get labeled long COVID. They go to long COVID clinics, which basically just document and accumulate data because we still treat them based on the symptoms, but giving it a label, sometimes the label ends up sticking and the symptoms stick. Until the system kind of falls apart.
I think we're touching a little bit on like the concept of disability identity and how some folks will really resonate with their diagnosis. And I think that is, it's hard and good, right? Because it's good because a lot of times the biggest diagnostic factor with FND is identifying and understanding that the diagnosis is the correct diagnosis. Right? But I guess going on the topic of disability identity, some folks will become champions and warriors over their Instagram and create a lot of positive enhanced expectancies for other people who are dealing with the same thing. And I think that goes a long way. So there's a lot of layers with disability identity that end up being one of the primary topics that our psychologists work with the participants here, but that itself could be a whole webinar itself.
Yeah.
There's a lot of validation in like understanding, a kid understanding what their disability identity is, what that means, what it looks like. And sometimes we talk about like, okay, if you were to take your patient hat off, right? You weren't spending your time going to doctor's appointments and coming to reactive and, doing health management all the time. Like, what would you be spending your time, energy, bandwidth doing? And that can be helpful too, is to explore that path and actually integrate it into therapy and not wait until they're better to do those things, but do it now.
Can also sensory overload be related to meal times be a trigger? And how often or how close do you get to work with dietitians?
Yeah, that's a missing piece in our country. We would love an in-house and the same roof dietitian. Send someone next door. But it can definitely be a factor in meal times. A lot of times it comes up as nausea, bloating, abdominal discomfort, belching or gagging. So what can be helpful is learning the kid's sensory profile, whether it's through informal exploration or using something like the adolescent sensory profile. So we can determine, small tweaks and changes to mealtime to deal with the sensory overload. We do refer to dietitians. We do work with dietitians. I just wish we could have one at like team meetings, because I think not every case has GI and eating issues, but I would say a good amount of them do.
Yeah, and then for like the kids with like mast cell activation syndrome, right? That a lot of times food can definitely be a trigger to them MCAS, which also their MCAS could also be a trigger for their FND symptoms too.
Yeah, we see kids, certainly I see kids with complex chronic pain, young adults, and sometimes they have EDS, IBS, irritable, Ehlers-Danlos syndrome, the non-diagnostic genetic type, so hypermobile, they're dysautonomia, they have POTS, they're dizzy, they may have chronic pain, maybe CRPS, back pain, some other pain, they may have headache, sort of a conglomeration of, and then they also have functional neurologic disorder. How do you deal with figure out a plan for the multi-symptomatic kid or young adult?
So those are the people that we treat the most, right? So
they're the ones I send to you.
Those people are our bread and butter. So I think it's when kids are coming in with like this long list of diagnoses, it actually paints a really great photo of them and what's going to work and what doesn't work immediately, right? So for example, someone comes in with everything you've mentioned, right? The whole laundry list, and I see POTS. Maybe my first plan is, well, let's see what happens to your FND or the rest of the whole system if we treat the POTS by adding a little compression, adding a little self-love, maybe a self-hug or a weighted blanket. What is that going to do to your nervous system? A lot of times, I would say maybe 80% of the times, that's it. That's the one thing, and it helps. And we don't stop there. We'll try to find other things too. So I actually find that when it's just FND alone, without any other comorbidities, that's when it's the hardest. because then I'm doing a lot of not diagnosing, but almost like what's the treatment and what is the nervous system really craving here that we can really boost.
Is full recovery possible?
Yeah, absolutely. I love this anecdote. I talked with a parent of a kid who had FND pretty recently, and she came here, in a wheelchair, not being able to use her legs at all, really weak grip strength, and then her head would kind of droop. She was here for about 10 weeks ish, and I talked with her mom, and her mom had called me and she said, "I have great news." And this is after she had done her program. She went back to running, walking, horseback riding. She called me and said, "I have great news." She forgot at a dentist appointment where it says past medical history, she forgot to write functional neurological disorder. And so you can almost imagine that it's like the book has ended. So you can totally expect full recovery for people with FND.
That's fabulous, fabulous news, because a lot of families worry about that. One question I want to ask parents, if you look on the website, there, Google FND or name it, there are gazillion supposed cures, and all kinds of people advertise with anecdotes. Somebody said, "Oh, I had this and I did this and I had ketamine, now I'm perfectly fine." And so there are a lot of things that may work, may not, haven't been shown. Some people may get better. I mean, people get better with placebos because they have strong beliefs that that's helping them. And those beliefs transmit in neurologic changes. So how do you help people not go to 5,000 different, around the country?
Right. That's a great question. I would say, like, you don't, this has happened one time, but you don't you don't have to be this person where you check the Cochrane review of what works for folks with FND and what doesn't. Although it has happened here. I think there's two parts of this question, right? There's one, the person who's over researching, and then two is like, where can they find really great resources on FND? I guess to answer that second one, to toot our horn a little bit, is on our YouTube channel. If you look up reactive physical therapy, we have our boss, Julie Hirschberg, who every week will go on to talk about something related to FND, whether that's having an interview with someone with FND, bringing up the brand new research on FND, or how it relates with EDS, how it relates to POTS, what is POTS, going through the fundamentals. I think FND Hope also has a really great website.
So one parent said your website says that you have virtual and in-person appointments, or virtual appointments, for people who live at a distance, used even at the beginning of treatment. And then related, is your program an inpatient or outpatient program?
Yeah, our facility is outpatient therapy, but again, it's not just the physical therapy in the name, it's also the occupational therapy, psychology, yoga therapy, psychology. And the other question was, virtual appointments. So we have done in-person and for all virtual. So we've done it all, and whatever mixes in between. When we've kind of looked at our outcomes of comparing what our in-person and our virtual sessions outcomes are, they're actually very, very similar. Everyone is reporting a really great big change. And I think it's just figuring out what's working for the nervous system. If, let's say we're doing a virtual session, we might need the parents a little bit more with the permission and accent of the kiddo. But we can certainly do both.
And we're all trained to work well over telehealth, and we see progress. And I reassure folks that there's not a difference in the quality of care.
Yeah.
Which is especially helpful too for costs. If some folks from Northern California, it saves them lodging and everything to come down here, right?
Yeah. Well, the two of you are fabulous. I want to thank you. There was a last question that I'm just going to answer. How can we join a parent support group? And I want to comment, Dr. Samantha Levy, who's on this list, runs an 8-parent, 8-week support group. It's more than support, it's educating parents on how do you take care of a kid, a teen, a young adult who has chronic pain. And, you know, and she only takes 8 people. So you sign up for the next group. We also have a once a month parent support group that Samantha also coordinates, and that's on our website. And I think that's a good parent support education way of learning more and how to be a parent of a kid with complex problems, and then getting your kid into the right program. And I'm going to ask, I have a half a minute, one last question of the two of you. Are there similar programs to what you have, like in San Diego or Northern California, that, or how do people find that?
Yeah, in San Diego, I don't know of many facilities that have this integrated treatment, but in Northern California, there's the Stanford program, and there's ones across the United States. If you go in the FND Hope website and click like search for a provider or a link for a provider, they have a whole list of places that treat FND. And not every place has that multidisciplinary approach, but I think that's a really great place to start.
Good. And I want to read the 3 takeaways. FND that you wrote here. FND is not faking it. It's multifactorial and caused by the perfect storm of everything happening at once. You can get better. You can expect full recovery. And the gold standard of FND treatment is a team-based approach, and it's not anyone's fault. So I want to thank you all, and I want to thank the two of you. Of course, I didn't expect anything less than fabulous, and it was fabulous.